someone who soon will be joining my alma mater institution where I went to college. And I had the privilege of showing her and her partner around Pittsburgh. And we had some cheese, some charcuterie, and a little too much champagne. Gabby, if you don't mind, unmute yourself. Tell us what you're doing next year and a few lines.
Yeah, of course. Thank you for this presentation, Reza. Yeah, we had so much fun in Pittsburgh with you and your partner as well. So as you all know, I'm a neurologist in Brazil, and next year, next June, I will start intern year at University of Pittsburgh, and I will do a neurology residency there as well. I'm very excited to learn more and more about neurology.
Thank you, Gabby. And maybe we can have Deborah first and then Shema. Also unmute yourselves. Tell us how you're doing and what's going on.
Hello, everyone. I'm Deborah. Here's a holiday for Easter, and a lot of people eat chocolate. I'm trying to do diet, but I don't know if I will be able. So that's it.
That's awesome. It's always hard to pass up on some chocolate where I wouldn't be able to. Shema, how's it going?
Okay. Hi, my name is Shema. I'm so bad at preparing a speech, so nothing comes into my mind despite the bad weather here. So, hi.
Oh, man. You know what's interesting? I think if they did a study of topics that people go to when they don't know what to say, weather is the #1 topic. I was in the elevator, Robbie, with our previous program director, Harry Hollander, who's a legend. And you know when you get nervous with like someone in the elevator, I was like, yeah, so the weather out there is pretty good, isn't it? In any case, let me pass so Robbie, you say a few words, tackle the first aliquot, and whenever you're done speaking, Gabby can start presenting the case.
So the weather is actually really good. Those are the words. Those are the words. It's a delight to see you all today. And yeah, the weather's great here in San Francisco. Oh, man. I love hanging out with you all. All right, Gabby, mic is yours.
Yeah, of course. So the weather is good here as well. I just had to say that. And now to the case, the chief concern is headache.
Boy, you know, I can't help but reflect on something that isn't the nature of the chief concern, but how a patient prioritizes the first words out of their mouth. And I think that it is so, well, one, I should also reflect on, there's another piece of data here, which is that a neurologist extraordinaire is presenting to us. So you have to use those in parallel, but I think that's in keeping with the word headache. If you think about it, I would say the vast majority of people who check into the emergency room with anything going on probably have some form of a headache if you push them. The people with a kidney stone, the people with gout, the people with anything probably have a mild tension headache associated with everything else that's going on. But what does it mean if the patient chooses to focus initially on the headache alone? And I think that tells you that you're probably going to analyze the headache space more closely, and that you're going to go into and analyzing that schema. But I'd say our first job is to make sure that there isn't a suboptimal triage by the patient. Meaning that, are we actually dealing with headache as a systemic feature of a systemic disease? And the patient chose to emphasize it because it is a systemic disease with a prominent headache, or there's an inherent reason for the patient not to be able to prioritize triage. And so this really goes back to a deeper reflection on clinical reasoning, where we fundamentally are not the people who are triaging first. It's our patients who are triaging their complaints. And we've set up our illness scripts and understanding of medicine to incorporate a patient's perfect triage, meaning we really prioritize the chief complaint HPI, and we're leaning into what the patient is choosing to tell us in their story. But that cannot go perfectly. And the reasons it doesn't go perfectly, or there might be cognitive impairment, psychiatric perturbances, substances, literacy, language barriers, economic reasons. I mean, the reasons that a patient can't triage a complaint are infinite. And unfortunately, what has happened is we have rendered judgment on those reasons and say the patient is a bad historian, but that's not true. It's that we have failed to recognize there's a reason for this happening. So whenever the chief concern is headache, the first step is to step back and analyze, has the triage been made correctly? Is this a headache that is truly front and center, or is there a headache in the setting of an abdominal catastrophe or thoracic catastrophe, and the patient has an appropriate triage? So I would do that first and then deploy my schema for headache. All right, back to you, Gabby, unless Prof. Rez has wisdom to add at this juncture. All right, go ahead.
Okay, so it's a 20-year-old female that presents with a 15-day history of headaches. She says that she feels a pressure on her forehead, only on the right side. She can point with one finger to the place that is hurting, and it is characterized as a circle of around 2 centimeters on her right forehead. The headache started 15 days ago and did not subside. It was continuous since the day it presented, and it's causing mild pain. So not a severe pain. It is not aggravated by physical activity, laying down, or the Valsalva maneuver. She denies nausea, vomiting, photophobia, phonophobia. She has never experienced a similar headache before. She denies neurological signs or weight loss. She has been having some night awakenings due to the pain. In the last 5 days, the pain started to have a pulsatile characteristic, and she began to use NSAIDs. So the pulsatile pain improved, but the pressure on the forehead persisted. 2 weeks before the headache, she had chills and myalgias for a few days, but these symptoms spontaneously ceased. About the previous medical history, she had gonorrhea treated 2 years ago. No medications. For family history, her mother has migraine. And social history, she's from Brazil. Nothing else in this box. So no tobacco use, no ethanol use or any drugs, and no allergies.
Wow, Gabby, you got us at the edge of our seat. And I will comment on this data, but then I would love for Robbie to comment from the clues that he's also picking up. I'll say right away, if this story ended at 15 days of headache without any of the associated symptoms, I think this is when it's really challenging for a neurologist in clinic to know exactly how aggressive to work this headache up. What I mean by that is we already know in our diagnostic armamentarium is an MRI, is an LP. Almost, I was thinking about a pulmonologist and what's in their diagnostic armamentarium, like pulmonary function test, CT scan, bronchoscopy, and biopsy of the lung. I was thinking of that because of a recent NEJM case. So I am going to answer this, but I would love to also just hear, because Gabby knows more neurology than I will ever know. So I would love to know at the juncture of just 15 days of headache, no other complaints, the way this patient presented, what would be her next step in management? But I'll tell you, what we're trying to do, I think Angelita summarized extremely well in the chat box. The question is, are we dealing with a primary headache, migraine headache, tension headache, one of the trigeminal headache syndromes, or are we dealing with a secondary headache? And this is going to be the most important branch point. And the secondary headaches, I think a simple way to approach that is think intracranial. So the brain parenchyma, the lining, the meninges, and the vessels. Just look at your own head and neck, eyes, sinuses, nose, jaw, neck, or as Robbie mentioned, could there be a clue to something systemic? So what my mind is doing is scanning this data to see if there's a red flag or red flags that may point us into the direction of a secondary headache. To give you an example, Gabby told us this patient had some myalgias and fevers before the onset of headache 2 weeks ago. So that should prompt all of us to think about an infectious etiology like a meningitis. But right away, when you sort of match that with the time course of 15 days, the common bacterial causes of meningitis are unlikely, like pneumococcal or meningococcal, because the patient is still alive and the headache is subtle. Then Gabby told us that this headache awakens the patient up at night. And that, in general, makes you think of increased intracranial pressure, whether it's pseudotumor cerebri or some kind of intracranial mass or cerebral venous thrombosis. And then I think the other red flag in headache is just the duration. So this is someone who's never really complained of headache before. And now 15 days have gone by and the headache has persisted, which prompted them to come to Gabby's clinic or emergency department. The other buzzword here was the pulsatile nature. When you hear pulsatile, it should make you think of vascular phenomenon, but you got to be cautious because my favorite mnemonic for migraine, which is just based on base rate of disease, always the most common cause of headache, is the pound mnemonic, P-O-U-N-D, and the P stands for pulsatile, and it's over 4 to 72 hours. That's the O. The U is unilateral. The N is nausea, and the D is debilitating. You don't need all of the features, but if you do have them, it really strongly supports that diagnostic possibility. So I'm going to pass the mic to Robbie, but I just want to step back and say, one of the most challenging things as a provider is to decide how aggressive you want to be in the workup, and you really got to challenge yourself. We're in a CPS right now, but I would love for this case to end with the patient was diagnosed with migraine and did really well, because that's often what the case will be. But I want to just pass the mic to Robbie to comment on anything. And Robbie's an ED provider. So Robbie, like if you see this patient in the ED, like how are you scanning this data and deciding what to do?
Honestly, that's such a great reflection about the division of headache, and I actually forgot the pound mnemonic. It was a really nice reminder of it. And I love that I'll just say that the way my mind works is I've actually lost track. If you asked me what are the features that push me towards primary headache or secondary headache, I have a harder time listing them. They just become kind of like an cumulative emotion that you feel when you hear a story. And this was, I think, best captured by a cardiologist who practices at San Francisco General, which is he always says his name. He's one of the incredible cardiologists there, whose name is escaping me now. Who taught me as an intern. He's like, how does this chest pain smell to you? And I'm like, what do you mean smell? Like, it doesn't smell like anything. It's the patient's, there's no smell to the story. He's like, no, you over time, like I can teach you all the individual features, but how does it smell like? And I feel like this story leaves me with a little bit of a weird emotion in the ER, because as Reza essentially outlined, there's so many features of this that are so reassuring. It's been going on for 2 whole weeks. There's no nausea, no vomiting, no photophobia, no neck stiffness, no elevated ICP signs, no meningeal signs. Like the list of no is so long. But then as Reza said, it's been going on for 2 weeks nonstop. So that is both tremendously reassuring, one, because it hasn't evolved into something else. And two, it is tremendously concerning because it has started out of the blue 15 days ago and hasn't gone away. So what am I trying to say? I'm trying to say that I'm not sure that this headache falls neatly into the categorizations that we have of primary versus secondary. And so what's my suggestion? You should have a list of things that break your schemas. And this is breaking my schema. This is literally the headache schema that we have is breaking it. And this is, by the way, my mom calling me. Perfect timing. It's breaking my schema for headache. I don't know, primary, secondary, I don't know what to do. And so I'm trying to generate a list of what are the secondary headaches that can sneak up on you, and what are the primary headaches that can masquerade as a secondary headache syndrome. And that's the exercise that we should try to continue to do for the rest of this conversation. What would I be doing in the ER? You know, migraine is a very humbling diagnosis, often made by response to therapy. So we often give patients like this a migraine cocktail, which Gabby can outline in more detail, but it usually involves a first-generation antipsychotic like compazine or an NSAID or hydration or magnesium or dexamethasone. There's many options. So that's probably what I would do in ER. And I would also be wondering about jumping to indomethacin, because indomethacin is a great treatment for some of these like really intriguing primary headache syndromes, but I would be very perplexed, and I would probably lean on my neurology colleagues to help me figure out this case. This is not something that I would go ahead solo. Yeah, I don't know how to feel with this. How are you feeling about this headache, Prof. Rez? Primary, secondary, or unknown?
I'm not sure. I'm right
Yeah.
there with you, my friend. And I'm just trying not to be biased in one direction or another by just this being a CPS. So maybe at the end of the exercise, I would just love to hear from like an expert like Gabby, how she processed the data. Thank you.
Yeah, so I think I wanted to say a lot of things, but I'm gonna say this, that when I saw this case, I had the same mixed feelings as you had. So she had some red flags, but some things were very expected and did not prompt me to do increase my investigation. So I think when I see a case of headache, I really try to use the SNOP algorithm to remember all of the red flags. So systemic symptoms, neurologic symptoms, onset for thunderclap, onset for older age, positional, prior history, pregnancy, and precipitated by Valsalva. So this patient, she had only no prior history and systemic symptoms. So she had 2 red flags. But at the same time, what was, like Rabbi said, the smell of the case was feeling strange for me, because I can be totally wrong for this, but at least in my practice, it's not so common for people to point to a specific part of their head. So she was able to point to specific circumscribed place of the head where it was hurting. And for most cases of headache, the pain is more diffuse. So this was a little bit strange for me. And at that time, I was thinking about a primary headache disorder, which is the nummular headache that Kirtan put on the chat. So it's one of the, so we have tension type, migraine, trigeminal autonomic, and the other group. And in this other group, we have 10 more rare headache disorders, and nummular headache is one of them. Basically, it has to have a round shape of pain that can be in one place or many places of the head, and usually in the scalp. I've never seen a nummular headache case before, but the presence of other systemic symptoms was really something that I considered in this case. And as a neurologist, I always, when I hear this story, I always think about how the neuro exam will be. So after the neuro exam, I try to think if I'm going to do systemic lab tests, or which kind of brain image I'm going to do, or if I'm going to proceed with the CSF lumbar puncture. So yeah, right now, I think, can I say, this is what I was thinking when I saw the case without the neuro exam. Would you like me to tell the exam now?
Please.
Okay, so regarding the neuro exam, it was normal, including normal fundoscopy, and she didn't have any meningeal signs. For the head and neck exam, she had pain due to palpation on the right forehead. She didn't have any rashes or skin lesions there. The sensory exam was normal in that region. Occipital nerve palpation was normal. Temporal arteries were normal. And yeah, the remainder of the neuro exam was normal as well. Reflexes, cerebellar, level of consciousness, cranial nerves, all normal.
Yeah, I'll just share a reflex response and then pass the mic to Prof. Rez to see what he has to add, which is one, I absolutely love the wisdom flowing in the chat, and nummular headache is completely new to me. I had never heard of it before, and excited to dive deeper into it, either in the rest of this case or after, either way. And I think, what Reza was teaching us before about secondary headaches, which is either they live in the brain or they may be right next to the brain. And I think the reasons to find something inherently wrong with the brain have diminished because there is no evidence of disease in each of the brain compartments, no parenchymal disease with focal neurological signs, no meningeal disease, no ventricular disease, and no vascular disease signature. And when you couple that with that, you can actually exacerbate the pain by touch. It's easier to see how the locus of pathology in this patient lies outside the brain somewhere else in the head. And so that's the progress that I would be making, but again, tempered by the fact that it's so I've never seen anything like this before. And so it's almost like we're saying that this patient has a skin problem that happens to be occurring on her head. You could have said this about any body part and the patient would have gone to a cardiologist for a chest localized discomfort that is palpable, or on the GI doctor for the belly, or maybe a primary care doctor for the leg. So what does it have to do with the fact that this pain is in the head? And that probably leads us to understand this more, but I can't do anything with that. I don't have the knowledge base to take that further. All right, Prof. Rez, mic to you.
So this can only be one diagnosis at this point. I'm just joking. Robbie, honestly, like listening to you speak, because reflexively, when we have a headache that's subacute, concerning, we all prioritize an MRI over a CT scan because we say it's been going on for some time. We want really good visualizations of that parenchyma and meninges. But after listening to you dissect this aliquot, I'm actually leaning towards a CT scan because of that localized nature, just to see for any quick structural abnormality. And doing a quick in real-time cognitive autopsy, I did this once before and I thought I wouldn't do it again. It's almost like hypothyroidism. We miss it every single time. And Robbie has promised he won't let me miss thyroid disorder in the future, but I don't know if he's lived up to it. But you remember that case that Emily Silverman presented me, and she was like, the nails were dystrophic, and I didn't comment on the dystrophic nails, and it ended up nails being in the final diagnosis of yellow nail syndrome because I wasn't comfortable with it. I think here, like, I don't know why my mind like just, stepped over the fact that the patient's pointing to it and actually like circumscribing the location of pain. That's such a unique feature. So I love that Gabby highlighted that. And I think it's really important to remind ourselves when something is not consistent with what we know, we need to pause and like ask the question, could that be significant to the final diagnosis? So I appreciate you, Gabby. And after listening to Robbie speak, I would be more inclined to get a CT scan than an MRI.
I just want to say one quick thing, which is usually at 9:30 on a Friday on an RLR case, we have 10,000 different things we're tracking of all the organs involved in a disease. And today, Gabby's like, the case I'm presenting you is a problem right here. And I have no idea what it is. Absolutely no idea. All right, Gabby, please give us more, please.
Okay. Actually, this patient, she went to the emergency room some days before coming to my office, and they did a CT scan there with contrast, and the CT scan was normal. So I ordered a brain MRI for her, but when she went to do the brain MRI, the same day she woke up, she noticed that the place where it was the pain started to, she started to notice a bump in her forehead. So right before she entered the MRI, this was a new finding that she didn't have before. I also have some labs and the result of the brain MRI. I don't know if you want me to tell that right now, or should I wait?
Maybe I'll just make a quick comment here before we get additional data. It's really intriguing that now there's a bump at the location of pain. It would make me want to actually examine it, because there's every reason to believe that whatever's happening on the skin adjacent to the CNS can manifest as a headache. So if that was, for example, like a vesicular rash, then I would think about zoster. And young patients can get zoster even if they're immunocompetent. I know they always teach us immunocompromised, but that doesn't necessarily hold true. So all that bump does for me, Gabby, is tell me that whatever this is causing the headache, either the primary site is right there on the skin and it's manifesting as headache, or could there be something internal that now is expressing itself external? I think for the reasons Robbie mentioned, that's less likely. But at this point, I'm worried about what's happening. Robbie, anything else to add before we get additional data?
Not my friend. Absolutely superb. Looks like Gabby has an image, so we'll make her a co-host and share it.
By the way, I did something sneaky there, because I know the next one might be an image that has to involve us interpreting an MRI. I quickly commented, because then it's Robbie's turn that's up to interpret any imaging findings.
Now that you played your card, I'm probably gonna have to do the same thing. We'll see.
Yeah, I still can't share my screen.
Try now, Gabby. I just made you co-host.
Yeah, now I can. So actually, this is the MRI. Would you like to comment, Ravi?
Oh, Gabby, I thought we were friends. What are you doing to me? Oh no, I will happily comment. I'll happily comment and pretend that I will have taken this fall for Prof. Rez. When you said, Gabby, would you like to comment? You literally moved your mouse over an area, which I assume will be the area I should focus on. I'm quickly looking at what part of the brain we can see, and I don't see anything there. And there's this marked asymmetry outside the brain, extracranially. And that's all I can honestly say. I don't really know what the nature of it is. It seems deep. So I'm guessing that there's a layer of skin that is actually symmetric. And under that initial layer, essentially behind the dividing black circular line is the abnormality. And so I think what this does for me is it makes it much more likely that the problem is from the outside. But I worry a little bit because the asymmetry initially that glanced my eye is all on the white layer. But then as I look closer, there's a perturbance in the subsequent, I think that's the skull bone, the skull base. And so if that perturbance is just reactive, I wouldn't care so much. But I don't think there's anything in the brain itself. There's something right next to the brain, and the divider, the skull base, looks like it might be involved either as a reactive process or a true invasive process. So I really, really need an expert's help in this. But I'm more reassured that it's not in the brain, and it confirms the suspicion that I think that this whole group has had all along.
Yeah, sorry that I don't have the full images, but here you're right. You have the T2 signal here, increasing the soft tissue in the frontal area. And when we saw that, we actually tried to see the CT scan that she had done some days before, and this is the result of the CT scan. So here you actually can see the lesion there. So there is usually MRIs are better for seeing like tumors and intracranial lesions, stroke, but for bone lesions, CT scans are better. So that's why we came back to see the CT scans, and the result was that she had an osteolytic lesion in the frontal bone with irregular border with adjacent soft tissue swelling. And here you can see that as well. Here, can you see my mouth? Yeah, I think you can, right? Here and I think, is it here? No, here. Yeah, here, here, and here. And here is the edema. And I have one more aliquot before the final diagnosis.
Awesome. Gabby, first of all, Robbie, I want to applaud you for identifying the abnormality. And then it's like, finally, there's a topic that you and I can discuss here, being osteolytic bone lesions. On our website, which I highly recommend you visit, Dan Minter and Chris, right, Robbie? It was a Dan and Chris who came up with this incredible bone disease schema. And there, they've often taught us that there's a difference between blastic lesion, like if you think about prostate cancer that has spread to bone, or lytic lesion, if you think about myeloma. But really, they all exist on a spectrum. So whatever causes lytic can cause blastic, whatever causes blastic can cause lytic. And when you're approaching bone disease, just like you approach headache, there are primary bone disorders and there are secondary bone disorders. And what I mean by that, just really quickly, like the secondary, you can think of cancers that have then spread to the bone. You can think of infections that have then involved the bone. And you can think about crystalline disease, sarcoid, and various other diseases that then involve the bone. The question is, are we dealing with a secondary bone process or a primary? I think based on the data we have so far, everything is pointing to this just being a localized disease of the bone. And I say that based on the lack of any B symptoms, the lack of any strong signal for inflammation. Of course, I'll be interested in some lab work to see if there's any signal to take us away from a primary bone pathology. Now, primary bone pathology can be benign processes that involve the bone, from bone island to Paget's to giant cell tumors of the bone, or they can be cancers of the bone, from osteosarcoma to Ewing sarcoma to chondrosarcoma. But I want to give the mic to Robbie too, to see what his thoughts are, if there's anything to take us away from the bone being the primary site of pathology.
Yeah, no, I completely agree with you. I don't think there's anything else. And I think when you're analyzing bone disease, you want to know what's the center of gravity in terms of systemic diseases, but also what other bones are either overtly or subclinically involved. And then you want to know what the alk phos is. I think the alk phos is a very, very powerful filter. For example, most cases of infectious bone involvement with osteo have a normal alk phos. Multiple myeloma has a normal alk phos. So a normal abnormal alk phos will help you, and that will take you very, very far. So I think what are systemic involvement, what bones are involved, and what's the alk phos are very helpful initial filters to put this through. And yeah, I agree with you. We now can get into general internal medicine mode. And I was so curious why Gabby wanted to present today and not on Tuesday. I was so curious, and I think we finally found the answer.
So should I say like the lab results? Should I say everything and the final diagnosis, or should I wait? What do you think?
Oh, my guess is, why don't you give us all the information right before you have an answer, so us and the whole chat can can go on a journey, which I'm clearly Prof. Rez is a fan of that answer.
Okay, so she was submitted to a bone biopsy and the result was osteomyelitis. There was no cancer signs there. And I think this is all that I can say. I still have one lab result.
Can I just ask, it's definitely Prof. Rez's time to reflect. I just wanted to ask one clarifying question, Gabby. When it says osteomyelitis, does it tell you the kind of cell? Was it neutrophils or non-neutrophils? And I ask because you can make a guess what the bug is based on what's responding. So was it neutrophils or non-neutrophil, or you don't know? Either option is fine.
Yeah, actually, I don't have this answer because I didn't see the result by myself, but I know it was osteomyelitis. So I don't know the answer.
Man, very, very humbling. And I think that, like, if we step back and say, was there any other clue to suggest a primary bone infection? And the truth is that there wasn't really, just maybe the myalgias and fever that the patient experienced at one time point. And it also speaks to something with regards to our body. Our immune system is really good at eradicating bacteria in the blood. In fact, each of us, for a few minutes a day, are bacteremic when we brush our teeth, etc. And our body is able to keep those bacteria under control as they enter our blood. The only time it's an issue is, for example, if you have some form of pathology on the valve in the bone that serves as a nidus for that bacteria to hang on to and then to propagate. So patients who have mitral valve prolapse or patients with degenerative joint disease are at risk of infection of the bone. So I think two things. One is I would, of course, be curious into the culture, the gram stain of this specimen. I would be open to sometimes a pathologist making a mistake unless an actual bug comes by, meaning that we're told osteomyelitis, but nothing is ever foolproof in medicine. But then I have to step back and ask the question, why would someone, at the age of 20, have osteomyelitis of the bone? Because the bacteria or the fungus or whatever organism has to somehow make its way to the bone. If there's no trauma, then that takes out sort of cutaneous to the bone, unless there's some microabrasion that we're not aware of. Another route, a common route, would be hematogenous. And when you start thinking hematogenous, you say, well, could there be an infection elsewhere on the valve? Some patients have AV fistula. Most people with poor dentition just have poor dentition, and that doesn't lead to anything. But it's really, I'm sort of stuck here, Robbie, not only asking the question, like, what organism might we be dealing with that's left its signature in the bone, whether it's like a gram-positive, your typical gram-positive organism like a strep or staph species, but then how the heck did it get there if this is infection of the bone? I would love to dance with you, my friend.
I'm similarly stuck there. It seems that we're saying that this is isolated. Even though Gabby was now moved away and other people were managing, like non-neurologists were managing this case, you can tell and deduce by their reasoning that they probably felt that this was the best site to biopsy instead of any other site. And so probably means it's the only, like guessing, it probably means that it's the only site, which is crazy. Like if you have osteomyelitis, why is it just involving the bone? And I have nothing to add to your wisdom. I'm just humbled by this case. And no matter what the answer is, I will learn a lot, because it is not something that there is no disease that I know of that aligns with this being an infectious condition immediately. And whatever it is, this will be a tremendous amount of learning for me. So I'm excited to learn from Gabby.
Yeah, thanks. So the HIV and hepatitis B and C serologies were negative, and the VDRL was positive 1 to 8. And syphilis IgM was also positive. So actually, I don't have the the culture. The bone culture was negative as well, and she was treated with 3 doses of penicillin benzathine. We are still waiting for the new VDRL to be collected, but the pain disappeared and the patient is feeling well. Follow-up imaging was negative for osteomyelitis, and the final diagnosis was secondary syphilis. And this patient had a previous syphilis serology from 2 or 3 months before that was negative. So this is one question that I have for you, actually, because I know bone lesions are more common in tertiary syphilis, but is it because of this serology that we can conclude that this is secondary syphilis because we don't have the timeline necessary for tertiary? Or what? I don't know. I want to hear from you.
Oh, so I'm just blown away. I need you to give me a second to process this case. I just did a quick Google search, and yeah, this has been described, skull-based osteo with early syphilis. I'm sure you have a lot more to say about that. So in terms of interpreting if it's primary or secondary, I think you have to, by definition, this patient is symptomatic, so they're not in a latent stage. So they have to be before a latent stage. And this is not a manifestation of primary syphilis. So I think by definition, when you have a newly positive syphilitic serology, it's newly positive over a period of time, and the patient is symptomatic, then it's secondary syphilis. The unusual thing would be that about 95% of patients with secondary syphilis have a rash, though it can be subtle. So in these, it's many cases of syphilis require you to go back to the patient and look at the 1 or 2 lesions they have on their palms and soles. But 5% don't have a rash at all. But yeah, I think by definition, this is too early to be a manifestation of latent syphilis. And because the patient has symptoms, it's secondary syphilis. It's a unbelievably crazy case of secondary syphilis, but that's another conversation. Prof. Rez?
Ooh, Gabby, thank you for bringing this case. What a phenomenal case for so many reasons, from whether to get imaging or not, to finally getting imaging, to then going after tissue, and then, sending that, even after getting the tissue of osteomyelitis, I don't know if that would have prompted me to send serology for syphilis, but I'm reminded of one thing here, and it's an important teaching point, that there are some diseases in medicine that travel together. For example, when someone has one nutritional deficiency, they're likely to have another nutritional deficiency. When someone has one STI, sexually transmitted infection, they're likely to have another sexually transmitted infection. So some diseases travel in pairs. But that being said, like I see the gonorrhea was 2 years ago. I would want to make sure that the patient is up to date with all of their STI screening. But then even if I would have thought about syphilis, I wouldn't have been like, oh yeah, that focal pain is consistent with that. So actually, Gabby, what prompted the sending of the serology?
Yeah, thank you. Actually, I just sent that on the chat. It was actually the radiologist who saw the MRI and the CT, and saw again the CT scan. He said there was a pattern of osteomyelitis there that resembled syphilis, but unfortunately, I don't know how to describe more than that. I have to study that, but it was some pattern of osteomyelitis.
And that's it. I just want to say one thing before giving the mic to Robbie. Like, the radiologists, to me, are the best diagnosticians. And you don't want to look back and say they always get the DX right, but they see so many images. And when they suggest a diagnosis, it should prompt, a clinical correlation. And I don't think there's any reason for any of us to know what that imaging looks like. But going forward, if I ever see a patient like this, I'll think of syphilis without even the radiologist mentioning it. So thank you, Gabby. Mike, to you, Robbie.
And that's why I disagree with Prof. Rez. I think he's the best diagnostician out there. Radiologists are a close second. Because look, I mean, that's the point. The point is, like, what makes you a great diagnostician? Simply just the desire to be one, and the humility to learn and grow every time, and to learn from other people. The reason I muted was to actually not add wisdom to this conversation, but to offer this radiologist the opportunity to name this sign forever and ever, because can't see it described in the literature, and clearly she or he should jump at the opportunity of forever describing it.
Would you want your name to be associated with syphilis to the end
Hey,
of
dude.
time? Let's call it a Robbie sign of skull syphilis.
See what I mean? See what I mean? He's the best and most shrewd and wise person. He's already thought a step ahead. I don't want to be associated with his sign. Okay, I think it's time for me to get off the mic, and I'll pass it to you, Gabby, for any reflections or wisdom you got from the case, and then of course to Deborah for our teaching points.
Yeah, I don't think I have nothing else to add. For me, I think it was very humbling to understand why primary headache disorders, why you have to exclude secondary headache disorders. So this was a good reminder. Syphilis is probably way more common than pneumolar headache. So for me, this was a very good case to learn that. And also, yeah, how we are better when we are in a group with other physicians like here, and like I had the help from this radiologist who was very important for us to have the final diagnosis. And thank you, it was a great discussion as always.
Yeah, big great case. Thank you so much. I think I always learn more and more about syphilis. With the teaching points, I learn a lot, and sometimes my brain don't follow too fast. So I have the help of Sammy, Marcella, Shema. So thank you so much, my friends. And the headache can be present like in systemic disease, like kidney stone, gout, emotional infections, like meningitis, and in this case, hazard triage can be corrected because can be some causes about that, like an abdominal or thoracic catastrophe, assistance, or psychiatric. And thinking about the headache can be primary, like attention from trigeminal, or secondary for infection, neoplasm, vascular, elevated ICP. And we have the pound that is pulsating duration of between 4 and 72 hours, unilateral, nausea, and disabling. And in the primary care, when a patient presents with the 4 symptoms, there is a probability of 92% to be migraine. And if it's just 3, it can be 64%. And we have to look for the red flags. SNOOP, that can be systemic symptoms, neurologic defects, onset, like a new or change, a thunderclad, an older age, and a papilledema, pulsatile, positional in pregnancy. And the MRI can be better for a tumor, stroke, and posterior fossa lesion. And the CT can be better to see the location for the bones, like in this case. And the bone disorders can be primary or secondary. Primary from osteosarcoma, chondrosarcoma, or secondary for cancer infections and surgery. And the diagnosed solitary of skull lesion can be metastasis, solitary plasmacytoma, infection, or a metabolic disorder. So thank you so much. We see you all tomorrow.
May I just say one thing? Deborah, your teaching was phenomenal. When I'm reading these teaching points, I watched someone end the VMR, but when I'm reading it, you add more than we taught. And it's like I'm reading a textbook. So thank you for that.